Hello, thank you for joining us. I'm Caroline Cruz, President and CEO of the Platelet Disorder Support Association. Welcome to ITP Insights, a series of webinars bringing disease education to patients, caregivers, and their families, featuring expert clinicians and researchers discussing critical topics in immune thrombocytopenia. I'd like to thank the sponsors of this program series, argenx, Principia, a Sanofi company, Sobi, and Grifols. Today's program, Living with ITP, Common ITP Questions, is a third in a series of quarterly webinars covering topics important to the ITP patient community. And to celebrate Global ITP Awareness Week and Sport Purple for Platelets Day, I'm joined by the leaders of two of the most active ITP organizations in the world, the ITP Support Association in the UK and ITP Australia. We'll start the program with common ITP issues like dental work, travel, food and diet, exercise, fatigue, and platelet donations, and then move to an important topic, shared decision making, and then give you an update on COVID-19 and ITP. And then the program will feature experts answering many of your questions. So here to kick things off is Danielle Boyle, CEO and founder of ITP Australia.
Hi everyone, Danielle here from ITP Australia in Land Down Under. Thank you so much to both the PDSA and the ITP Support Association in the UK for including ITP Australia in this set of this webinar. We're actually really excited to be involved, and I want to introduce our speaker. So today, the Director of Haematology at the Princess Alexandra Hospital in Queensland, Australia, Robert Bird, will be joining us, and he and I sat down and had a chat with regards to some of the common questions that we see and that patients ask around ITP. Thanks, Rob, for joining us today. And thank you to everyone in obviously the UK and the US that are joining us as well for this webinar, which is really exciting. Okay, so what we're going to do today is we're going to ask Rob a couple of questions around the common questions asked around ITP. And we're going to start with dental. So what do you need by count to visit the dentist, whether it's for a general clean checkup or, fairly decent, major dental work? Is there a guide?
Look, there is, but it's very rough. I mean, I guess the thing is with ITP, there'll be a person who has a platelet count of 20, has a bruise or mark on them. Then there'll be other people with the same platelet count who'll bleed. So while we can give platelet counts as a general guide, it does very much depend on your, personal history. So generally speaking, to go to a dentist and get a clean and scale, in other words, just sort of general checkup, it's recommended that you have a platelet count of greater than 20. For simple dental extractions, and by simple, that would really be the incisors, teeth, platelet count of greater than 30 is recommended. And for more complex extractions, so that would be the back teeth or the molars, really a platelet count of greater than 50 is required. But look, my oldest son's a dentist, and I've sort of spoken to him about these things. And, there's dental extractions and there's dental extractions. Some teeth come out really easily, 5 minutes, it's all over. Other times, it's sort of an hour of relentless struggle in the chair for both the dentist and the patient. So there is a bit of variability. But I think the important thing is let your dentist know you've got ITP. Don't turn up and just assume everything will go well. Certainly, I find not infrequently dentists will contact me if they've got patients with ITP just to get some reassurance. And the other thing I'll just comment on is people do get gum bleeding. People without low platelets get gum bleeding, and really the most common cause of gum bleeding is not a low platelet count. It's really gum disease. And gum disease really needs a proper sort of dental scaling. And so it's normal to get gum bleeding when you get dental scaling, whether your platelet count's 20 or 250. But if you are regularly bleeding following brushing your teeth, it may well be that you've got gum disease really, rather than just reflecting low platelet count. So paradoxically, that is a reason to go to the dentist and get everything cleaned out, and which obviously at the time may make things worse, but then is likely to settle things down. And just one other thing he said is, obviously, I think you don't want to be using a hard toothbrush. And, you know, there is apparently a skill to brushing your teeth. I'm not sure I have it, but that can be sort of largely offset by using an electric toothbrush, because then really the brush does all the work rather than your elbow doing the work. So if you haven't got a good dental, you know, toothbrushing technique, using an electric toothbrush, and you can get them for as cheaply as $20 these days, is a fairly good way of letting the brush do the work without causing as much trauma to your teeth as sort of a standard manual toothbrush would.
That's wonderful. Is there anything that you can recommend, obviously, other than going to the dentist and checking for dental gingivitis or something like that? Is there a mouthwash to help with bleeding gums if it is ITP related? Because I know personally, when my counts are low, I've got bleeding gums, but generally when my counts are fairly good, they're not necessarily.
Yeah, look, you can use tranexamic acid. It's not so good as a mouthwash, because then, you know, the drug is only just in contact with your gums very transiently. If you are bleeding from, you know, and similarly, if you have dental work or tooth extractions, then tranexamic mouthwash soaked in gauze pads and just applied to the area of bleeding can help. But again, I wouldn't just assume it's low platelets. If you are regularly bleeding from your gums, it's likely you have some gum disease. So I'd get it checked out and just don't assume it's low platelets, because it might be something that can be readily fixed by a trip to the dentist.
Wonderful.
So in other words, you want to treat the underlying condition really, if you can, rather than just the symptom. Not the symptom
itself. Yeah. Okay, moving to travel, which is something that I think we're all missing and have been missing for the last 18 months, definitely. Yeah. When it comes to flying, now obviously in Australia it's a very big country, but and a lot of our a lot of the people in the UK and the US are now able to travel quite a lot. But what are your recommendations when it comes to having ITP and safely flying?
I have no idea where this comes from. I think this is a bit of an urban myth, this issue that there's potentially a problem with flying. Now, obviously, you know, if you're in a plane and it goes down, whether you've got ITP or not, you're in big trouble. And if there's an emergency decompression, which is where, you know, like a window blows out, you know, you can get a massive decompression. That's like diving and coming up quickly. You know, you can get what's called barotrauma, which is sudden decompression. But really, just routine flying, it doesn't really present a substantial bleeding risk. So I think rather than the process of flying, which really is not intrinsically dangerous, is, you know, if you're someone with really unstable ITP, it's really where you're going to, and the fact that on the way there, whether it be in a plane or some other mode of transport, you know, you might be in a situation where if things are really dicey, you're not in a position to get help if you need it. But obviously, I would hope that most people with really unstable ITP or any other disease wouldn't be taking the risk of flying. But, you know, if you've got reasonably stable ITP, there's really no particular platelet count that which you should be striving to achieve before you can fly. It's a safe sort of process. Obviously, with long haul flying, you know, there has been, you know, there's a risk of prolonged immobility. If you don't take enough fluids, you might get dehydrated. And ITP, as I'm sure most people know, does confer a mildly increased risk of blood clots, you know, despite the low platelet count. So if you are on a long haul flight, I think the important things for people with ITP, as well as people with no health issues, is to get up and walk around as much as you can, keep your fluid intake up. And I do not refer to alcohol, I refer to water or similar. Really, you know, keep a good fluid intake up, keep moving. Most of the flight magazines will have some little exercises suggested that, you know, keeps the circulation going. But, you know, do those things, common sense things for anyone who's traveling long haul, really. But yeah, but in terms of ITP and flying, I wish I knew where this came from, because, you know, there really isn't an increased risk of bleeding unless something, you know, catastrophic happens on the flight and, you know, everyone on the flight's in trouble. That, in that case, not just those with ITP.
Yeah, no, it does come up quite a lot, actually, in the when patients are sort of talking amongst themselves, or if someone's about to go travelling, you know, things like travel insurance, which is generally readily available for ITP patients now. Even travelling, you know, to not to lower socioeconomic locations like Thailand and that sort of stuff as well. It's still available. It is available, which is great.
Yeah, look, the other thing, I guess, is if you do have to take medication with you, it's probably as well to take a letter just from your treating doctor, just certifying that the medication's needed. And possibly if you're going to a country where English is not commonly spoken, it might be worth getting some kind of translation. But yeah, aside from that, I would certainly encourage my patients with ITP who want to travel, just to discuss it, to see whether it's a safe journey to take. We have quite a network of ITP specialists around the world, and certainly when people have travelled before to various points in the world, people who've potentially would need treatment while they're away, we can often tee something up. So yeah, just talk to your treating specialists, if you've got problematic ITP, because we can often facilitate treatment overseas rather than having to go through an emergency sort of process.
Yeah, well, that's great. Okay, moving on to food. This is generally a fairly big topic. Loads of people, swear by diet changes, cutting out gluten, having things like papaya leaf extract. Have you experienced anything that's sort of outside of the ordinary, particular minerals, vitamins, supplements, that sort of stuff that can help?
Look, I guess the thing is, for the most part, unless you have a specific deficiency of a vitamin, taking more of a vitamin that you're not deficient in really isn't going to make a substantial difference. And in some cases, you can run into trouble with, like, for example, nicotinic acid, which is now being sort of promoted as a cure to, as a drug which can sort of resist in eternal life. If you take too much of that, it can actually cause thrombocytopenia. So really, there's not a lot of role for vitamins unless you're vitamin deficient in boosting platelet function or boosting platelet counts. Similarly, there's a whole load of sort of mythology around things that interfere with platelet function. So certainly there are some dietary supplements, or there are some herbs, for example, that if you take them in large quantities will have a minor impact on platelet aggregation, that is the platelet's ability to stop bleeding if you cut yourself. But for the most part, really, so for example, onions, blueberries, garlic,
turmeric as well, I've heard. During that period that there was that turmeric coffee, everyone was like, oh no, you can't have it. It's like, well,
yeah, look, the thing,
I've got to have a truckload, right, for it to actually impact.
Well, you would. That's absolutely right. Look, if you somehow can invent a process to sort of distill whatever it is, so most of these things like onions, ginger, they have a specific chemical in them, which if you could purify it and concentrate it and take it at a level which would be far higher than you would get just by eating these things in normal quantities, they may have an anti-platelet effect, but you'd have to eat sacks full of onions, or as I say, have some kind of bizarre distillation process going to extract that chemical and concentrate it and take it for it really to make a difference day to day. So look, if you want a bit of garlic or onion in your stew, go ahead. It's really not going to make a difference apart from make it possibly taste a bit nicer.
I know, I'm Hungarian. We can't stay away from onion and garlic and that sort of stuff. So no, I don't think I could survive without those ones.
Yeah, look, there are specific drugs, that have anti-platelet effects. Obviously, aspirin, clopidogrel. There are many drugs like the non-steroidal anti-inflammatory drugs, which if you take them long term will have an anti-platelet effect. So you really need to be avoiding those sorts of things long term anyway. But most dietary supplements have a very modest effect on platelet function, and as I said, unless you're going overboard with them, it's highly unlikely to make any significant difference. So I certainly don't think common foods that you can buy at the supermarket and eat in normal quantities, I don't think we really need to be avoiding any of those.
And obviously, talking to your clinician and depending on what treatments you're on as well will impact that as well, I suppose. So
there are certain drugs, there are certain things where, grapefruit or Seville oranges, for example, contain a substance that can interfere with the metabolism of certain drugs. None of those are commonly used in ITP, but, there are certain drugs where, fruit has an has a chemical in it that interferes with their metabolism. But you will generally be informed about those things when you start taking them. And obviously, if you're a person who takes L-Trombopag for ITP, there's a whole load of things that can interfere with the absorption of L-Trombopag or Revelade. So divalent cations, which are things like iron, zinc, copper. People can start taking supplements, for example, because they think they'll help, and they can actually do the opposite to what you'd like. They can stop the absorption of L-Trombopag. So again, if you're thinking of starting a supplement for your general health or for your ITP, really just check with your specialist first, because you may inadvertently be taking something that could, adversely impact, not through a direct effect, if you like, but by a sort of indirect effect of really limiting the absorption of the treatment that's supposed to be helping you.
Okay, so moving to exercise. With exercise, obviously, in adults with ITP, do you recommend, patients not engaging or, participating in certain types of exercise? Obviously, the benefits of exercise from a mental health perspective are quite good, but do you have any recommendations there at all?
Yeah, really, you want to be avoiding contact or impact sports. So things like rugby, gridiron, or boxing, or sports like horse riding, where if you do have a fall, you could get quite significant injuries or trauma. But certainly things like walking, jogging, swimming, those sort of aerobic exercises, rowing, absolutely, I would encourage people to exercise using those sports. It's really those high impact sports, sports where you're essentially trying to injure people, gridiron, rugby, boxing.
Yeah.
Don't put yourself in harm's way by engaging in those sports. Do something, aerobic type exercises, running, walking, swimming, rowing, plenty of options. Just not
yoga, all of those sorts of things as well. Because obviously the benefits of those exercises can help alleviate some of the side effects when it comes to things like steroid use and those sorts of things as well, and the anxiety felt by patients just in general with ITP.
Look, I think there's evidence across the board in a whole number of chronic illnesses beside ITP, but showing that if your general level of fitness is good, you regularly exercise, you just feel a lot better than if you're not exercising. So I would certainly encourage people to exercise, stopping short of those contact sports.
Wonderful. Okay, in general, we all there have obviously in the I Wish survey we found that fatigue was experienced by quite a lot of patients and a big proportion of patients. Is there anything that that patients that you think that that they can do to help alleviate that fatigue, or is it just a sort of sit, relax, listen to your body type messaging? Or
look, it is tricky, but the fatigue seems to be a common symptom in ITP. It's some people I look after absolutely can predict their platelet count by how they feel and get very fatigued with a low platelet count and feel better when it's higher. However, that's not a consistent feeling, and there is something about the disease process maybe that makes people fatigued, because there are other people that you can treat a low platelet count, improve it, and fatigue doesn't always improve. So there's not always a clear correlation between platelet count and degree of fatigue. Treatment with steroids or with romiplastim or L-Trombopag may not necessarily improve fatigue. So it's a tricky one. Look, I would say, fatigue is a very difficult thing to deal with when you've got it. But I would say, if you can, try not to give in to the fatigue. Try and keep up a level of exercise and, activity. Because I think one of the risks of fatigue is you do less, you don't feel any better, you do even less, and then you get to a really low level of fitness and deconditioning, and then it's really hard to get going again. So irrespective of the fatigue, if you've really become very sedentary and try to get going again, it becomes even harder. So I'm not saying really push through your fatigue to ridiculous levels, because that can make things worse, but just try to keep going with those daily activities, and if you can, a bit of gentle exercise, because if you give in to these symptoms completely, sometimes it can be very hard to, pull yourself out of that hole and get going again. And yeah, look, it's hard to say. Look, obviously, in some people, you might be worried about, you shouldn't exclude other things like, depression could be a contributor. So that's something that might be worth discussing. Now, your haematologist is not necessarily going to be the expert in depression or management of depression, but certainly it's something that, if you bring that up with your haematologist, it might be worth seeing a psychologist or even a psychiatrist if depression could be a factor.
That's good to know. I know personally that when my husband actually does a platelet donation, he normally does a double or a triple donation, and he comes home absolutely wiped out. And it's sort of like, well, yeah, that's how we feel when with ITPs. Goes and watches Netflix and sort of has a sort of not a day off, but he just takes it easy a little bit comparatively. So, but yeah, it was quite interesting to see that he had that experience as well when it came to donations. Talking about blood donations, obviously ITP patients here in Australia aren't able to give a blood donation. But one thing that I thought was actually quite interesting was that women, especially that have had children, can't actually donate blood either. Donate platelets. Sorry, not blood, but platelet donation.
Yeah. Look, that's to do with a very rare condition called TRALI, transfusion-related acute lung injury, which is a condition where plasma can contain antibodies that can cause that syndrome. And it's, so really women can donate plasma, but that plasma is then sent for fractionation into different plasma components. It's not used as what's called clinical FFP, or it's not used for, if you like, resuscitation of people with major bleeding episodes. It's sent off for fractionation to make, things like blood clotting factor concentrates or fibrinogen concentrates, things like that. So certainly you can, as a female with children, donate plasma, but it will be sent down a different channel to male plasma. In Australia, anyway. I don't know. Yeah. I don't know the arrangements in other countries. I imagine it's likely to be similar though.
Similar. Okay. One of the big questions and big comments that I suppose that are asked amongst the Australian patients especially is that, okay, so I'm now experiencing, I don't feel myself, I'm experiencing, an increase in symptoms. Should I wait and see? Should I go and seek medical advice? And they're actually asking other ITP patients. What's your recommendation there?
So you're saying if someone with ITP develops some new symptoms. Look, I guess the thing is, if you've had ITP for a long time, you're probably very familiar with the symptoms, which suggests that your ITP might be getting worse. But if you're relatively new to the game, you may not recognise those symptoms as indicating worsening of ITP. I would say, get a blood test, see if you can, get along to see your doctor. It's better to be safe than sorry, and pick these things up early rather than just let things progress and get worse. So if you get any new symptoms, you've got a chronic disease, really get them checked out. If they're if you're already familiar with them, certainly if you've got symptoms suggesting your platelet count might be very low, again, just get in touch with your treating specialist, and hopefully things can be headed off before they get worse.
Yeah, better to be safe than sorry, I think.
Yes,
definitely. Okay, one final question. It's ITP Awareness Week this week. Have you planned to do anything for Awareness Week this week?
Well, as you know, it coincides with my birthday most years. So I have a dual celebration, and my son's birthday, which is very close to mine, who I briefly referred to earlier. So yes, we generally have a week of celebration. My wardrobe isn't replete with purple attire, but I'm sure I can find something to
wonderful, put on. Wonderful. Well, hopefully you can post a photo or two sporting some purple or your pin or something like that over the course of the next couple of days. That'll be great.
I'll do my best.
Don't forget to tag us.
Okay, thanks, Danielle.
Thanks so much for joining us today.
All the best.
Thank you.
Thank you, Dr. Bird and Danielle. And now here to talk about shared decision making is Mervyn Morgan, CEO of the ITP Support Association.
Hello, everybody, and welcome to ITP Awareness Week 2021. My name is Mervyn Morgan. I'm the CEO of the ITP Support Association here in the United Kingdom. And I'll be talking today about something that's very, very dear to us at the moment in the UK, as we published this document this very week. It's a Shared Decision Making Toolkit for ITP patients, entitled Making the Right Choices in ITP Management and Care. Well, firstly, what is shared decision making? In the United Kingdom, we have an organisation called NICE, which stands for the National Institute for Health and Care Excellence. They come up with the following guidelines. Shared decision making is a joint process in which a healthcare professional works together with a person to reach a decision about care. It involves choosing tests and treatments based both on evidence and on the person's individual preferences, such as beliefs, values, and lifestyle. It makes sure that the person understands the risks, benefits, and possible consequences of different options through the medium of discussion and information sharing. Now, the objectives of the toolkit has a number of strands, but the two main ones are here. Firstly, empower patients through updated educational materials, which can include patient information, various treatment options, and holistic support. Secondly, improve treatment and care for patients via refined processes around collaborative decision making between the patient and clinician on the treatment and care plans. But before we go into the details of the toolkit, there are two main partners involved in this project: the ITP Support Association and the UK ITP Forum, which come together to form the working group, the ITP working group. Firstly, a bit of history about the ITP Support Association. We operate in the United Kingdom and Ireland. It was formed in 1995 by a lady called Shirley Watson. The aim is to promote the general welfare of ITP patients and the families of patients with ITP. The ITP Support Association's patient information resources are freely available for ITP patients, their families and carers, as well as medical professionals and researchers. And they provide advice and literature on how best to deal with the condition, helping people better understand ITP. As part of the normal day-to-day work of the association, we also run a yearly convention from which we have patients, healthcare professionals taking part. Because of COVID, the last couple of years these have been held virtually, as have our local ITP support groups. We have a network around the country, and again, because of COVID, these are now being held virtually. But I must say attendance has improved with the virtual format. Secondly, the other main partner is the ITP Forum here in the UK. This is a working group of healthcare professionals who have a special interest in the care of patients with ITP. They include haematologists, registrars, and clinical nurse specialists. At the last count, I believe there's about 70 or 80 healthcare professionals on this forum. In addition, they also have the ability to audit the various ITP specialist centres that we are blessed with to have around the UK. So they come together to form the ITP working group, which is a multi-stakeholder task force, which involves, as I've said, patient advocates, patients, healthcare professionals, and health policymakers. The group was established in 2020, and it seeks to identify the challenges associated with delivering optimal ITP management and care in the UK, and provides guidance and solutions to them. Now, the toolkit was developed in response to the ITP Support Association's 2020 Patient Perception Survey, which provided evidence of inconsistencies in the diagnosis and management of ITP, which impacted on patient outcomes. In October 2020, the ITP Support Association, with support from Amgen UK Limited, convened a policy roundtable, out of which came a document called Understanding the Challenges Faced by Patients with ITP. The roundtable identified that enhanced shared decision making on treatment and care issues is important to improving the quality of life of ITP patients. A working group was established to ensure the smooth preparation of the ITP toolkit, specifically to focus on developing educational materials for patients, carers and clinicians. Other biopharmaceutical companies and professional bodies such as Genetic Alliance UK and the Royal College of Pathologists in the UK have endorsed or supported the promotion of the toolkit. During the life of the project, we held 3 workshops. These took place with the roundtable members to agree the best practice guidance for shared decision making and the scope and design of the patient-focused toolkit. The toolkit was prepared so that it could be publicised during ITP Awareness Week to patients, their families, as well as healthcare professionals. The toolkit link can be found on the ITP Support Association website at www.itpsupport.org.uk and their various social media channels. I mentioned the ITP working group. These are the people who were on the working group. As you can see, many of the names will be familiar to people watching this broadcast. It's a who's who of ITP. These people will be familiar both in the UK, Europe, and in America and Australia, but they come together with one aim in mind: to produce this document. Now, the structure of the toolkit. The toolkit is divided into 4 main sections, and I'll go over them one by one. Section A, the toolkit offers information on what is ITP and how an individual may become affected by the condition. And the booklet actually guides you through the journey that many ITP patients will have. Section B, the toolkit offers a definition of collaborative decision making. Decisions over the treatment and care of ITP should be a bilateral discussion between patients and clinicians. This allows the patient to gain knowledge, skills, and confidence over their conditions and treatment options. On the other hand, clinicians can tailor treatment and care around the needs of the individual, e.g., a treatment that well combines with a patient's lifestyle, therefore improving prescriptions and the quality of life of the patient. Section C, the toolkit provides guidance on the steps that should occur from diagnosis of ITP to the choice of what the best treatment options are available. And, you can see from this flow diagram, you need to actually download the document, to really dig into it. Section D, the toolkit explains the different types of treatments available for ITP, providing guidance steps for patients in choosing the best treatment that suits the individual's lifestyle. And finally, the toolkit offers links to other useful information that a patient can read to further their knowledge on the condition, including links to patient booklets, patient treatment options, and much more. And as I said, the booklet is available to download from our website at www.itpsupport.org.uk. There is a link on the screen now, but if you just go to our website, it will take you straight to the page and you can download the document. So in PDF format, we are also getting hard copies printed. So if you do need a hard copy, please email us at info@itpsupport.org.uk and we'll gladly put some in the post for you. Okay, thank you very much for listening. If you have any questions, please put them in the comment section on social media, where you're viewing this broadcast, and we will endeavour to get back to you and answer any questions that you have. Thank you very much, everyone.
Thank you, Mervyn. Mervyn will be back after this presentation to ask your questions of our ITP experts. But first, we know based on the calls and emails to the PDSA office and to the ITP Support Association office and our Facebook pages that anxiety around ITP and COVID-19 is still at an all-time high. So here to give us an update on COVID-19 and ITP is PDSA medical advisor and world-renowned ITP expert, Dr. James Bussell.
Thank you very much, Caroline. It's a pleasure to get to present to the audience on an important topic, and that is vaccination for COVID-19 and ITP. I'm showing you here a slide illustrating that platelets are actually very active immune cells. They're considered part of the innate immune response. And for coronavirus in particular, it can infect them through the toll-like receptor 9. They have a lot of functions here, and you see again illustration of how they can interact with immune cells and immune molecules in a lot of different ways. It would probably be better if we understood how all these functions related in individual settings, which we don't that well yet, but it explains why ITP can be relatively common and can be seen with infection and inflammation. We think in a lot of cases, and this is best shown for the varicella or chickenpox virus, that you can have what's called molecular mimicry. And in this article from many years ago, antibodies to the varicella virus cross-reacted to and bound platelets. And that may be how coronavirus induces ITP and how vaccines induce ITP as well. We don't know this at all for sure. It's just a leading hypothesis. So I'm going to talk to you about vaccination and ITP. And this was all triggered to a large extent by the fact that there was a very previously well 56-year-old physician without any known comorbidities or any medications who received the Pfizer-BioNTech vaccine. 3 days later, presented to the emergency room with a platelet count of 3,000, and 13 days later passed away from an intracranial hemorrhage after his low platelets were resistant to treatment with steroids, IVIG, platelet transfusions, and rituximab. So this led to the idea that people who never had ITP wanted to know what their risk was with vaccination, and especially, and we'll cover this in the second half of the talk, what happens to people with ITP pre-existing who get vaccinated. So we're looking at data in the first part primarily from VAERS, which is a CDC and FDA sponsored website that's the Vaccine Adverse Events Reporting System. And this was the data I'm going to present to you it was data from VAERS last accessed on March 19th. And there were also a number of patients that we'll touch on briefly who I heard about through email following an earlier article we did and some coverage of this problem in the New York Times. We also then, for ITP patients, had 10 centers, 1 in the UK, 9 in the US, that collaborated with us, giving us data on platelet counts of ITP patients following COVID-19 vaccination. I should say our data is almost entirely Pfizer, BioNTech, and Moderna vaccination data. So it's all 2-dose vaccines. We have very little J&J data and essentially no AstraZeneca data in the presentation. In addition, both PDSA and the UK ITP Patient Support Association provided us information, the latter via Adrian Newland, who will be on the call with us to discuss questions about ITP in a little while. So, sorry, this is just a reminder about which vaccines it is. So after the vaccination occurrence in December, January of the gentleman in Florida, we looked at 20 patients in an article published in the American Journal of Haematology. And we could not really very clearly estimate incidence, though it seemed like 1 in a million based on what we had accessed and the number of cases of ITP. But again, all of this requires for these cases that the ITP be symptomatic, and it may be a little more frequent. It tended to be after the first dose, and we hypothesized that it could also be an accelerant in the sense that it would be hard to generate an immune response to the vaccine and have ITP be very symptomatic 1 to 3 days later. Yet approximately half the cases occurred in the first week following these vaccinations. So that would suggest that maybe these people who developed ITP had asymptomatic ITP and didn't know about it. In June 2021, in Nature Medicine, a national registry in Scotland reviewed the 4 million plus population and concluded that there was no increased incidence of ITP after the Pfizer vaccine, but there was possibly after the AstraZeneca vaccine. And in their setting, the great majority of people had received the AstraZeneca vaccine. However, a very recent British Medical Journal article looked at millions of patients in the UK and demonstrated that after either a COVID infection or first or second doses of Pfizer and AstraZeneca, that there was a clear spike of ITP in the 2 weeks after infection or vaccine. So this would make sense, suggesting that there is a small increased incidence in ITP following these vaccines and infections. When we looked at the VAERS data, we had 67 of 78 where we knew which vaccine dose it was, and 52 of those it was after dose 1. Developing ITP didn't relate to many of the variables you might think of in ITP, given that since this was in March, the data was through March, that would be when primarily older people were vaccinated. So that might have hidden the age-associated incidence, if indeed there was one. And it appeared that pre-existing autoimmune disease might be weakly associated with the occurrence of ITP. Was this ITP in any way bad? And while we've summarized all this, and this is in an article that was accepted fully last week by Blood, in general, the answer was no. The platelet counts were very low, but in the people in whom we had information about response, 27 of 29 responded to steroids and IVIG, and we have no information yet on whether their ITP is particularly chronic or not. We did hear about 8 additional patients who had not responded to IVIG, steroids, platelet transfusions, and in 6 out of 8 cases, rituximab. We tried adding 1 dose of vincristine in order to achieve a rapid response and a thrombopoietic agent, usually romipilstim, for those non-responders, and they all responded. It's worth pointing out that rituximab is probably not a good choice for treatment in this setting because first, it typically takes 1 to 8 weeks to work. It eliminates the effect of the vaccination that's just been received, and it doesn't allow revaccination for a half a year or more. So, summarizing cases of de novo ITP, primarily because some people with ITP think they have de novo ITP, and even if they identify their ITP months after vaccination, and also because it's been instructive in what happens. And as we said, it's rare. Standard first-line treatments work in the great majority of cases, and there's additional therapy that can be used if need be. So, not surprisingly, patients with ITP, which was pre-existing, on the one hand would ideally choose to be vaccinated, But at the same time, we're worried that they could develop severe thrombocytopenia, or at the very least, have their ITP destabilized if they received a COVID vaccination. And I think from what I told you about where we got the information I'm going to tell you about, the ITP community mobilized together to really provide information to their patients. So we had the 10 academic centers, and there were 70 patients with before and after counts for both doses of a 2-dose vaccine. Platelet Disorder Support Association has had a very large survey, and they provided us an initial group of 59 patients, and they're well up into the hundreds now. And they submitted an abstract to the American Society of Haematology meeting reporting on this. And the UK ITP Support Association provided us with 43 patients because many of the hundreds of people who cooperated and collaborated with them had not obtained counts because they were not symptomatic. And I should point out that while the 117 patient cohort is people who got counts whether or not they were symptomatic, many patients in the PDSA and the UK group, and probably at the academic centers who did not get symptomatic, chose not to have counts. So the numbers I'm going to give you may overestimate what happened. So of the people who were vaccinated, most were women, and women particularly predominated in the less than 50-year-old group. The pre-vaccination platelet counts were a median of 2 weeks prior to vaccination, and 3/4 were within a month. And 69 of the ITP patients out of the 117 were on treatment, most of those on TPO agents. 24 patients have previously undergone splenectomy, and that'll be important in a minute. And 16 of the 45 who were not on treatment had normal counts. Now, if you look in green on the top at the 101 and 100, you'll see that remarkably, there was no difference in the median platelet count before and after SARS-CoV-2 vaccine. If you look at the next bullet, that's because platelets went up in 32, remained stable in 43, and decreased in 34. So that was very nicely balanced. And I'll show you some of that information in a subsequent slide. We arbitrarily created a ITP exacerbation, which was either having your counts decrease by more than 50% to a level less than 30, or having your platelet count decrease by more than 100,000, or by needing rescue medication because your counts fell very low. So on the one hand, 17 patients, or just under 20%, had their counts exacerbate, and 10 of those did get to less than 30, but only 7 received rescue treatment out of the 117 where we knew about the first dose. So this is a very small number, which I think is hopefully reassuring. I should say now, and it might come up again, that all patients who received rescue responded to it. And rescue could be a short course of steroids, an increased dose of a TPO agent, something like that. The point of this slide, which says, if you had a decrease of more than 50% after the first dose, if you had a decrease of 20 to 50%, if you were stable within 20%, an increase or a big increase, how did that relate to what happened with the second vaccine dose? And the best thing we can say, because it was somewhat inconsistent, is what you did with the first vaccine dose did not predict what would happen with the second vaccine dose. Ways to express that would be to say, in the bottom 2 graphs, if your platelet count increased after the first dose, or the top one on the right, if it remained stable, relatively few people had their platelet counts drop precipitously after the second dose. Conversely, though, if your platelet count decreased after the first dose, you didn't automatically get into trouble with the second dose. And while there were 7 people receiving rescue treatment after the first vaccine dose and 9 after the second vaccine dose, there was only 1 patient who received it after both doses. And again, to reiterate, when rescue was given, it was virtually uniformly effective. And when the count decreased, it tended to get back to normal, or back to baseline, I should say, within 2 to 4 weeks. So we talked about this, but it isn't possible to perfectly predict. If you do well the first time, it's pretty likely you'll do well the second time. And the current recommendation on the PDSA website is to get a count about a week after a vaccination to see where you are. Who were the patients whose counts dropped? Splenectomized patients and those who had received 5 or more previous ITP treatments had a high odds ratio, meaning for splenectomized patients, they were 8 times as likely to have a substantial decrease. And this was whether or not their counts were good beforehand and whether or not they were on additional treatments. Very interestingly, the preliminary data that we had in the 71 patients from the PDSA survey and the 41 from the UK affirmed these findings, in that previous splenectomy appeared to increase your chances by a lot of having a substantial platelet decrease. So last 2 slides, only a bit over 10% of vaccinated ITP patients had a substantial decrease. Many of those did not need rescue therapy, universally effective treatment, no major bleeding, and you need careful monitoring, especially for splenectomized patients and those with aggressive disease. Of those who had a big decrease in their platelet count in the 117 patients, 13 of 16 of those with major decreases had either undergone splenectomy or received 5 or more previous treatments. And we believe it's very important, and I think the recent data suggests this strongly, and is the reason to think about booster doses, that getting a second dose of the vaccine and maybe a booster protects against COVID variants. So I'd like to thank all the people who contributed to the data, especially Dr. Andrew Lee and Marina Beltrami-Morera, and the PDSA and the UK patient associations, and the other people who contributed patients from the 9 other academic centers. Thanks very much for the opportunity to talk about this.
Thank you for the great COVID-19 and ITP update. Dr. Bussell is going to stick around to answer patient questions. And now joining us is Mervyn Morgan and Dr. Adrian Newland. Mervyn and I asked our members to submit questions for both of you to answer, but most of the questions are around COVID. So let's start with boosters. Dr. Bussell, are ITP patients considered to have an immune deficiency that would qualify them for a booster vaccine? And if so, should they be concerned about getting the shot or an additional shot?
Whoa, that's a complex question. So first, I think you can probably imagine that ITP patients are not one thing. They're very heterogeneous, a lot of different patients, a lot of different underlying issues. So if some of them may have ITP because they have an underlying immune deficiency, then yeah, I would say they could be special candidates for boosters. There's some data, but not brilliant data, I think, on what happens if you're taking an immunosuppressive medication. We know, for example, that after rituximab, there's not much point in vaccinating for at least 6 months. We have some data from patients on, I believe, MMF that suggests that may impede vaccination response also. So it's kind of a flip. On the one hand, you may be immunocompromised, and that's why you don't respond. On the other hand, you may need the vaccines more. I would say, as far as that's concerned, if you're vaccinated and if you don't respond well, and you and I were talking before about, at least in the US, that you can obtain testing, then you might want to be leaning to the monoclonal antibodies, which increasingly are going to be used preventatively, not just post-exposure. So complex question has to be, I think, very individualized. Adrian, do you want to add anything to that? I'm sure you have some interesting thoughts on it.
I agree with your comments. I think, and it's a point that comes up increasing in the UK as well. And the point we make that ITP per se is not associated with poor immune response, and that they should respond well. But certainly, many of the treatments almost certainly will blunt a response. It depends what treatment they've had, how long they've had it for, and in part also their age. And we know that older men tend to respond poorly to vaccination anyway. So my advice is, in general, certainly in the older people, to go for a booster, and for others, if they've had recent treatments, then yes, or they've had extensive treatment in the past. But taking your point about rituximab, where there's no point in vaccinating within probably 6 months of a course of rituximab.
Caroline, you also asked about if ITP patients are at special risk, and the short answer would be we have no idea because we don't have the experience. I think the data with 2 doses, like in other words, before we get to even a third, suggests that getting a second dose is not particularly worse at all than getting a first dose in patients with ITP. At least that's what our data has suggested that Adrian contributed to. And so I would say that shouldn't be a reason not to get it, the fear that your platelets would go down, but I would encourage monitoring a week after, as we would anyway.
And Dr. Bussell, then what about patients who've had a splenectomy? Because in your presentation, excuse me, you showed that folks who had had a splenectomy were more prone to have a platelet drop.
Let me just reemphasize that data was not only in the 117 patients from the 10 academic centers, that was in the PDSA survey data, and that was in the UK survey data as well, at least in the results we had available to us. So on the one hand, yes, that maybe they are definitely at increased risk. On the other hand, they may be at increased risk of infections, though I don't think anybody has suggested that COVID is worse in that group, though I haven't seen any data one way or the other. So bottom line, I just think they should monitor carefully and have a plan with their hematologists, like what would they do if their count falls. As we talked about, when that happens, treatment seems to be pretty universally effective. Adrian, you want to?
Yeah, I think the data has been very interesting from that. And I don't feel from our data here that someone with ITP is more susceptible to COVID. They may have more problems if they catch it. So I think they need to be more aware. I think the issues relating to the vaccines is an interesting one, and our later data suggests that the degree of thrombocytopenia post-vaccine is greater with the Oxford AstraZeneca vaccine than with the others. We didn't see that in the first tranche, but we have seen it is more prominent, although it's still relatively a relatively small problem. So certainly, if there's no other choice, we would recommend the AstraZeneca, but I think probably the Pfizer vaccine or the Moderna vaccine in the UK would be the ones to go for. I know the Oxford AstraZeneca vaccine isn't available to you in the States, but that's certainly from our data here.
In the UK at the moment, it's flu season time, so they're rolling out the flu jabs, and in a number of areas they're actually jointly doing the boosters and the flu. So one injection in each arm. And you wouldn't believe the number of questions we've had asking, firstly, is it safe? And secondly, shouldn't there be an interval between the two injections? Gentlemen, any observations on that?
I think that's a very interesting question. And again, one I don't think we really know the answer to, although there's been a lot of speculation. And I heard some discussion from our experts over here very recently, who suggest that actually giving them together boosts the response. So I don't see there's necessarily a downside of having them together, although of course you do get thrombocytopenia with both, although those numbers are small. I guess something like 10 in a million with the flu jab. It's been slightly greater than that, with I think it was about 7 per million in the UK data in these are non-ITPs with Pfizer, and about 22 per million with the AstraZeneca. And so they're pretty small, and I think, as Jim was alluding to earlier, with COVID, the rate is actually considerably higher than that. So the downsides of the infection are significantly worse than potential problems with the vaccines. But I see no issues with having the flu jab and the COVID booster at the same time.
In pediatrics, we tried, you would have a thing where a kid would have ITP and they would have a bunch of vaccinations that were due. General policy was to try to split them up to lessen the chance you would make things worse. On the other hand, I don't really know any data on it. So Adrian, if you have any information that you alluded to, that it might actually be better to give them together. I know there's a small Australian series of about 10 patients, and the 3 patients who had the worst ITP were those who got the flu vaccine and the COVID vaccine in close proximity to each other. So my instinct would be to try to separate them, but on a public health thing, it might be better to just go ahead, give both. The chances of anything happening anyway are pretty small. I just think we don't know in an ITP patient what would happen with the two together.
Yeah, I think that's right. We don't know in ITP. Certainly the data that was being quoted, I've seen no published data to support that. This is just from the experts on the UK panels, the vaccine panel, suggesting that this is what they thought was the case. I think you can't second guess what may happen in ITP from what happens in the normal individuals. I mean, as an interesting aside, of course, as you know from the data that you've collected, the platelet count often will rise post-vaccine as much as it will fall. So it's you can't predict what will happen.
Dr. Bussell, we've actually had a couple of members who were diagnosed with ITP after getting a flu vaccine. So they're very nervous about getting the COVID vaccine. So would the monoclonal antibody treatment be a good alternative for them?
Yeah, I think we still don't have them available, at least in the US, to prescribe routinely prophylactically. I think if they had an exposure, for sure, whether it's somebody in their household or at work or whatever, if they're identified to have COVID, then I think anybody now would be a good thing to be receiving one of those. And there are additional trials, as you may know, ongoing to look at other agents beyond remdesivir. Even I was surprised to learn we're going to be studying, we in the US, not me personally, ivermectin, which I had not thought was a serious contender, but you never know.
Yes, there's a lot of veterinary dosage usage of ivermectin, people self-treating, which I think we should tell people not to do whatsoever. That if they are going to try it, it has to be taken under strict medical supervision and probably in a trial situation. Just to come back to the point of people who develop thrombocytopenia or ITP post-vaccine, I think we have to be very careful there, because we know that at least a third of people with ITP have no symptoms and are picked up but when they have a blood count incidentally. And I just suspect that if people develop a thrombocytopenia within 1 or 2 days of a vaccine, that may be flaring up underlying ITP that they previously weren't diagnosed. I think a true thrombocytopenia secondary to a vaccine comes at least 10 days to 3 weeks post the vaccine. I think a very rapid development of thrombocytopenia may be lighting up a previously low platelet count. So I think we just have to bear that in mind as well, because we very rarely have pre-platelet counts on people who later develop thrombocytopenia. I mean, we don't often have that even in some of the ITPs. And it's only those who have low counts or are very worried about it, because we don't recommend they have a count routinely.
I think the flip side of that, though, I've been starting to hear now from patients who got a vaccine, let's say in March, and then they develop ITP in, I'm making this up, July, and they're very concerned that the vaccine actually triggered it off. And I think that's kind of long, and we don't really know if they developed it very mildly, never found out about it, and it got worse exactly the way you're describing, and as we said in the article we have coming out, or if they have ITP totally independently, and now everybody's associating everything with the vaccines.
Yes. I had some discussions with someone very recently who had just that scenario, developing a low platelet count, presenting with an acutely low platelet count some weeks after the vaccine. And I found it very difficult to think that that was related to the vaccine, unless they'd developed a chronically low count post-vaccine, which I was unconvinced with that as an argument. So I think a lot of things are being blamed on the vaccines now that may not be related at all. And certainly when I look through the MHRA data, which is the healthcare regulatory authority in the UK that collects side effects, and you look at the list of side effects, and some of them are just bizarre beyond words that people have thought that they want to declare, and you can't see any association, rational association whatsoever with the vaccine.
Okay, I've got another one that's linked again with vaccines, but at this time it's from a mother. She's got two children. One's 12, one's 14, and as you're aware, Adrian, I'm not sure if you're aware, James, but in the UK they've now given the go-ahead for children 12 to 16 to be vaccinated. Now, she's got no problem with her 14-year-old son being vaccinated, but her 12-year-old boy, he had ITP when he was 2, shortly after having the MMR vaccine jab. And he's now been in remission for 4 years. And she's very, very concerned that giving him the COVID vaccine might, flare up his ITP again. Adrian?
Well, I would say maybe Jim would like to comment first, as he had more pediatric experience than I did.
I don't really have a good answer. I was a little disappointed that we were not able to tease out data about previous vaccine response to current vaccine response with COVID. I've seen tantalizing snippets that suggest if you do something with one, you might with another. Again, I think both the chances of something happening are low enough, even if they're 20% or whatever. Nobody, I think, has any real idea, or at least I don't. And the risk of COVID is high enough, especially also if you bring it home and then give it to somebody else in the household, that it's worth getting the vaccine, again, monitoring it, and again, thinking it's likely you would be able to manage it fairly readily should anything happen. But I'm generally in favor of that, and a statement, at least from the PDSA Medical Advisory Board, favors generally the idea of vaccines, though we have much less data in children. So, Adrian, do you? I'm sure.
Yes, I think that's right. We don't have the data, and we know that COVID in children of that age is a relatively mild disease, and certainly a lot of the rationale for immunization in this country is to reduce that pool of potentially susceptible people who could pass it on to others, and also the impact on schooling. So it's the more social and public health issues relating to it. I can sympathise with the mother's worries about that, and certainly for our patients who had a platelet count fall post a flu vaccine are very reluctant to have it again. And even though the gap was so wide, I think it's very difficult to say to a mother like that, he has to have the vaccine, because I think there aren't strong, cogent medical reasons for doing that. But I would suspect if he did have it, the risks would be extremely small. But there are still potential risks.
Mervyn, I realized I forgot to say something, and Adrian and Caroline, there is very limited data on this, but in patients who got the MMR and developed ITP, whether caused by it or not, and then received a second MMR later, they have a very low incidence of developing ITP. So that might be a little bit in favor of saying you could go ahead.
Well, I was going to say our advice in adults, because of the risks and the problems of the infection, is to go ahead and get it. And if there is a risk, if there is a thrombocytopenic response, we can deal with it. We know that the vast majority, particularly if you're potentially alert for it, will respond to treatment quite quickly. And very few of our thrombocytopenic patients who developed thrombocytopenia post-vaccine actually required any treatment whatsoever.
Well, here's a question from a patient, an ITP patient in Australia, who wants to know, we have AstraZeneca or Pfizer. Is Pfizer a preferable choice for me due to the possible risk of blood clots? And then a follow-up question from this same patient is, what would you give as an alternative to rituximab? Dr. Bussell?
Okay, many parts to that question. First, they threw in the question about blood clots. So I think that's an area where it's a little clearer. The very rare incidence of the thrombocytopenia syndrome, at least, is clearly higher after AstraZeneca than it is after Pfizer-BioNTech. So I think for some reason, the adenoviral vaccines, including J&J, have a higher incidence of that than the mRNA vaccines. Now, you can also get blood clots without the thrombocytopenia, and I think that's probably a little more nonspecific, and as you know, can also be seen with COVID itself, and may just be part of the inflammation that Adrian alluded to when he was mentioning that your platelet count can increase after the vaccine. Not that the higher platelet count gives you clotting, but it's generally thought of as a sign of the inflammation that occurs. So I would say go with Pfizer over AstraZeneca if you have a choice. Also, Adrian alluded to, and the Scottish data suggested that there's a little higher incidence of ITP after the AstraZeneca vaccine than after the Pfizer-BioNTech vaccine. So that would be my choice. Adrian, what do you think?
Yes, I agree totally with that. I think initially I would have said I don't really mind which you have, and I'd support both. And actually, if there is no choice but the AstraZeneca, and they generally a choice, but there is no choice, then take that. I think the data would now suggest that probably from the point of view of both the issues of thrombosis, thrombocytopenia, and just thrombocytopenia by itself, the Pfizer is probably a safer option. And I certainly in our patient population, that's what I would recommend now. And it's interesting that in the UK, who are just now embarking on the booster program, they're giving the Pfizer vaccine as the booster.
Interesting. I think it's important, and Adrian, I'm pretty sure you would agree with this, and you actually made the point that we're talking about relatively rare occurrences occurring a little more frequently with, let's say, one vaccine than another. But I think we would all be strongly in favor of vaccination. So there's no reason not to get the AstraZeneca vaccine, and that's like 1 in 100,000 or less anyway. So we're not talking about a public health menace that we're avoiding. We're talking about, if you have a choice, slight preference in favor of one versus the other.
Yeah, yeah. But it's interesting from the MHRA data, even with the Pfizer vaccine, there's a proportion who develop the cerebral venous sinus thrombosis, but it's not the same as the thrombosis associated with the AstraZeneca, and they don't have the thrombocytopenia, they don't have the antibodies that identify this as a post-vaccine phenomenon. So it's important to remember that CVST is still a phenomenon that occurs in a small but significant proportion of the normal population, and it occurs actually a lot more in patients who develop COVID, but it does develop in patients who have the Pfizer vaccine, but it's not probably related to the Pfizer vaccine. This is just the normal epidemiology in a normal population, and it's really it's post the AstraZeneca where they develop the VITT syndrome.
Let me ask you about two ITP treatments. I know that there's a study with fostamatinib in patients who get severe COVID. So for ITP patients that are on fostamatinib, do we know if it offers them any protection against COVID? And then the second question is about ITP patients who receive IVIG. Are there any protective COVID antibodies in IVIG? Dr. Newland, I'll throw it over to you.
Well, coming to the second point first, there are almost certainly no protective antibodies to COVID in ordinary polyclonal IVIG. I mean, we know that people get coronavirus infections. Their coronavirus chest infections are in the normal community, just not the type of COVID-19. And I think that in the polyclonal IVIG population from normal donors, any coronavirus antibodies there would be at such a low level as to be actually irrelevant. And I know certainly early on, people tried to use IVIG in the UK and elsewhere, and it made no difference whatsoever. So I think there's no benefit or relevance to IVIG in this population.
As you know, I'm married to Charlotte Cunningham Rundles, and
yes.
And she has actually done studies on antibodies to COVID and IVIG, which were not there in the beginning, when the pandemic started, but are there more now. So Charlotte, would you say there are useful antibodies to COVID and IVIG or not?
It would be impossible to say that they are useful, but they're certainly becoming more present. And the other thing is, it depends upon the expiration date of the gamma globulin, which is no surprise. There's a 3-year shelf life of gamma globulin, and its donor to bottle is 1 year. So that if the expiration date is 2024, it's probably going to have spike antibody and nucleocapsid antibody. And if it's in 23, it'll be less. If it's 22, it's less. If it's 21, it's non-existent.
Thanks, sweetie.
I think that's useful. I wouldn't have been so dogmatic if I realized Charlotte was around the corner.
We've done somewhere around 125 lots of 7 different products, and I'm getting my patients to send me their gamma globulin from home because the home care companies are they stockpile it, and what that means is the home care patients are not getting any much because they're using their stores rather than the new stuff.
Yeah, that's very interesting data. Very interesting.
It also brings
and subcutaneous, by the way, is less because I think it takes longer to get it in the bottle.
Yeah.
It also, I think, is fair to say that in general, on any kind of commonly tested level, we don't know, oh yeah, you have antibody to spike protein. Is that good antibody? Not so good antibody?
We don't know if it's neutralizing.
Right. You'd have to test for neutralizing. Even then, it's not 1,000% clear. But I apologize. I wasn't trying to blindside anybody. I just thought it was useful to get somebody who knows about it to make
Absolutely. That's really nice data. Yeah.
And can I answer the fostamatinib question, or do you want to?
Yeah, sure. Yeah.
Do?
No, I've seen the data from Rigel, but you probably know it better than I do.
So I think it was clear from the ITP studies that fostamatinib had both some antithrombotic and some anti-inflammatory effects. Not surprising, because the enzyme it inhibits, SYK, tyrosine kinase, is intimately involved in inflammation, as is BTK for that matter, which is the one that's inhibited by the BTK inhibitors. So I'm not sure who had the idea first. I know that Nicola Cooper was very involved in it, of looking at it to see if it would be useful as an anti-inflammatory. And a pilot study at the NIH, which I think Adrian's alluding to when he says he's seen the data from Rigel, that pilot study suggests it's useful as an anti-inflammatory, the way that dexamethasone or even maybe tocilizumab, an anti-IL-6, is useful in reducing the inflammation so you don't get as sick when you're infected. Going to ITP and saying, do you have protection? I don't think we know. I think very fortunately, there have been very few ITP patients who've been severely ill with COVID. So I don't think we could say for sure.
Yeah, I'd agree with that, those statements.
All right, Mervyn, I think that's it with the COVID questions, so I'll turn it over to you.
Okay, thanks very much, Caroline. Thank you. Professor Newland, just, earlier this week, we, the association published a shared decision making document, which is called Making the Right Choice in ITP Management and Care. And that was produced by the working group that you very, very kindly chaired for us. And what a great job you did on that. I've been reading other publications and documentation within the NHS about various comments people have made over the years regarding shared decision making, and some comments such as, the healthcare professional considers themselves to be the one who should be the decision maker at the end, and they don't see how decision making, shared decision making, differs from their usual practice. Would you say that things are moving on now, especially with the publication of our document?
I think things are moving on, and obviously we decided to produce the document just because we had so many comments from patients that they wanted to be part of that decision, and it's all part and parcel of individualizing patient care, personalizing it to what they want, their age, their social circumstances, their weight, their jobs, all those sort of things. And it's been picked up more generally as well, that are the NICE, the institute in the UK that not only looks at drugs, but also looks and develops guidelines. Last year put out a document on pursuing shared decision making. And we looked at what had been done with one or two other diseases as well, in particular in patients with renal disease, where they're quite good about that. And I think that's an important example when you consider the options of dialysis or transplantation. But we felt that it was an important thing to do because of the age range of patients with ITP, because of their differing problems. So we developed a group of people from the ITP Clinical Forum, which is a group of clinicians who have an interest in that, and those who have specific interests. And we brought in Sue Pavord, who has the interest in COVID and thrombocytopenia, and also the issues relating to VIT, but all the usual culprits we brought in. Plus, we brought in patient representatives as well, who we found through the ITP Support Association, to produce a document that went through several iterations. And I have to say, I think it's a really very nicely produced document. We had a great team who pulled it together and did the graphics. The Royal College of Pathologists and the Royal College of Physicians have agreed to endorse it. We're waiting to hear if our general practitioners will as well, but they have other issues at the moment, and the rare diseases and the Genetics Alliance have also come to support it. And I think the need for something like that has been shown by the fact that it's been downloaded 800 times in the last 24 hours. I think that's a phenomenal response that I wouldn't necessarily have expected. So I don't know if either Jim or Carolyn have seen that, but I think it's a document that is actually of its time, and I think it's real support for patients. You hear the argument that patients will say to you, well, I want the doctor to make my decision for me because they know what the treatments are and what they have to offer and what my disease will do. But I think it's extremely important that even if the patients do leave the decision to the doctor, they're aware of the issues, they're aware of the whole wider perspective of their disease. Do they need treatment or not? If they do need treatment, what sort of treatment do they want? Do they want tablets? Do they want injections? How will it curtail their lifestyle? This is particularly important, not only in adults and children, but in that group in the middle that I'm sure Jim knows only too well, the adolescents who have the additional problems of their hormonal imbalances and their issues of not wanting to talk to adults, and particularly their parents anyway. So I think it's a document that's come out at the right time certainly for us in the UK, and comes on a wave of wanting to get patients much more involved in what we're doing with them. And I think they should, quite rightly should be. We shouldn't be paternalistic anymore in offering treatments.
I mean, in the past, at the yearly PDSA patient meetings, a major complaint would always be in large numbers about the physician not understanding and not knowing, and too much steroids for too long. And we know that both the international consensus report that Adrian was intimately involved with withdrew, and the guidelines have really commented on that. I think a phenomena that's happened that contributes to what Adrian was saying about shared decision making, and it's catching on more, is that as everything has gotten more specialized, I think physicians recognize steroids and okay, you've had it for a while, I keep having to give you steroids, and now we will go ahead and proceed to splenectomy. So they recognize that there's more out there. And with the patient support associations, the patients have access to information that they can usefully take to their clinicians. And I haven't seen the document, but I'm sure, Adrian, it would be incredibly useful to have something like that to go with. One of the things, just as a short anecdote, is connected with the COVID ITP question that's in de novo occurrence of ITP. Patients would contact me about what to do. Treatment wasn't working. I mentioned there were about 8 of those in the talk I gave and in the paper. And when I would say, let me talk to your physician. And when I contacted physicians, I expected to get blown off, to have people say, leave me alone. I know what I'm doing, the old school approach. But actually, they were very welcoming and very happy to know about it and happy to hear and so on. And I think that's contributing to shared decision making in a big way. The last thing I would say is, unfortunately, in the US, the idea that you have to see your patient in, let's say, 15 minutes, and you can't afford to be late for seeing the next patient, or you'll get dinged on your evaluations and so on, is a movement a little bit against that. You don't really have time to explore a lot of the issues that are involved in making a good shared decision about doing things if the clock is ticking and you have to write your note as well as that. But I think it's a great movement. The ICON group, the Pediatric ITP thing of North America, published a paper a year or 2 on that. And I'm thrilled that you did that and can't wait to read it.
Thanks very much, Doctor.
I just wanted to add that we know from our ITP conference, and PDSA had hosted a patient-focused drug development meeting back in 2019, We know that some of the quality of life issues and burden of disease, like fatigue and anxiety and depression, aren't always recognized by physicians and aren't always discussed with physicians. So I'm sure having this type of document, Mervyn, or this type of tool will help to facilitate those conversations between an ITP physician and a patient, or an ITP.
Yeah, I think that's a really good point, that that issues like fatigue and quality of life are being pushed at us by patients. They haven't been really driven by physicians themselves. Some physicians have picked up on that, and our group, international group, have talked about it amongst themselves for some while now. But it was a lot of push from patients that brought that to the fore. And I think Jim made a really good point earlier, that the issues of you go and see a physician and their immediate reaction, particularly if they don't have a lot of experience of ITP, they remember deep down from med school that you give steroids and it doesn't work, you take the spleen out. And that's one of the reasons for developing the ITP Clinical Forum, which is sort of 18 or so centres in the UK, where you have people with a specific interest in ITP who hopefully develop links with the hospitals around them. So they have this sort of hub and spoke arrangement. So we move away from this concept of this is what we do, steroids, splenectomy, what do we do then? Oh, immune suppressives. There are now a lot more options, so you can teach people locally. And of course, the PDSA and the ITPSA have produced a lot of documentation now that really help the patient so they know what's going on before they come out. And I think a document like ours strengthens them more to say to the physician, well, I've seen all these problems with splenectomy. You may tell me it works in 2/3, but that means in 1/3 or 40% it's not going to work. Why am I taking steroids all this time when the new guidelines say we should limit it to 8 weeks? So I think sometimes patients find very hard to challenge doctors over those decisions. And I hope that what we've done, what these two main organizations have done, and I hope that our shared care document does as well, is supports, and using that term, empowers patients to feel strong enough to say to the doctor, I'm not sure I want that, or do I have to have treatment now? Perhaps can we just follow it? Is there a reason why we shouldn't just follow the disease and see what happens? Or something that I, again, came in touch with just in the last week of someone who finally responded to mycophenolate, has had a good response for 2 to 3 months. The physician wants to tail it down, but she wants to go and visit her relatives in December, January abroad, having not seen them for a while. And she's, of course, worried if she does tail it, the count will collapse. They'll have to reintroduce it, make it take a while to respond. Is there any problem with her just remaining on it till she goes till she gets back from her holiday? And I think that's something she was a bit worried about saying to her physician. And I hope that what we're doing and what the association patient support groups are doing is actually helping the patient to get the facts to say, well, actually, there's no long-term reason. There's no reason I shouldn't continue this on long-term, or conversely, I've responded for such a while, I'd actually like to stop it now. Is there any reason why I shouldn't? So I think it's all part of a process of us working with patients. I mean, some of us feel that we did it anyway, but we probably didn't do it as well as we should have done. And I think the issue of having time to talk to patients is a very important one. Now things are getting very busy post-COVID for us. But I think the whole idea of having your multidisciplinary team, so I can chat to a patient, but I've got my clinical nurse specialist who can then spend a lot more time because she's not pressured in the same way that I would be, or other clinicians would be, who are trying to get through their every 15-minute consultation. So I think it's a good way forward, and I think it's responding to patient need.
Well, I think you've just answered most of the questions I already had on that. But if I can just close this bit, Caroline, I just want to quote something from the Med page, and it's something you wrote earlier this year. that I think is very, very apt for shared decision making. And I quote, "To improve patient management in ITP, we should move away from treating patients in the same manner to a more individualized approach according to the patient's probability of serious bleeding, response to a particular treatment, and the outcome on a patient's most bothersome symptoms, in addition to the risk of adverse effects or complications." That was you, Caroline. I think it was in May this year. And, to me, that quote encapsulates most of what is shared decision making. So, well done, young lady. So,
well, thank you.
Caroline, can I add one thing? Just
Sure.
Everybody, I think, on the call probably knows that Novartis sponsored a very large quality of life in ITP study. And it was published primarily back-to-back in the American Journal of Hematology in, I think, early 2021. So in terms of the background for a lot of what we're saying, that provides a lot of very good information about how troublesome ITP is to the typical patient in many ways, and different ways to approach it, and how there's discrepancies between physicians and patients.
Sorry. Yeah, that was the I Wish survey, I believe, wasn't it, Jim? Yeah, was involved in that. Yeah.
Thanks for mentioning that, Dr. Bussell. And I want to thank both of our ITP experts for joining us today. This was a really important discussion, so beneficial for ITP patients. And we're celebrating Global ITP Awareness Week. And we've been very fortunate to form this international coalition with 32 patient associations from 27 countries. But I think the collaboration between PDSA in the US and Canada, and of course the ITP Support Association, and then we had Danielle Boyle and Dr. Bird join us from ITP Australia. I think it just strengthens the work that we do as we continue to raise awareness around the world. So thank you both for joining us. And Mervyn, anything else you'd like to add?
Yeah. I'd just like to say, I think, the way forward with this condition, especially around the world, is cooperation between all the organisations. That, to me, I know I sound like a politician, but it is a special relationship. And it's good to see that today we've had the USA, UK and Australia, and no one's mentioned submarines at all. So,
well, somebody from France, now we could be talking.
But, thank you very much, Caroline.
Yeah, I was going to say we did not leave the French group out intentionally.
No. But thank you very much. I think it's, this is a, let's say, historic first, having a joint webinar like this, and let's hope there's far more of them as well in the future. And we have the technology, so yeah.
Mervyn, I think we owe you and Caroline and I guess Danielle Boyle and others a huge vote of thanks, because as Adrian says, a lot of things have come out of the patient organizations, and you two have been at the forefront of this and helping to make things move forward on lots of different fronts. So I think hats off to you for everything that you're doing.
Thank you very much, sir. Thank you.
Thank you. And Mervyn, I should just mention, both the ITP Support Association in the UK and PDSA have COVID surveys that I believe yours is still open, as is ours.
Yes, it is. Yeah. I said to Jim earlier, we're now up to, on this tranche of it, 400 returns, 300 or 400 returns. So I'm going to send him over the latest spreadsheet. So yeah.
Yeah, and we have around 500 participants so far. So both those surveys are still open. So if you've received your COVID vaccine, please go in. If you haven't yet, go in and fill out either one of those surveys or both of those surveys. And with that, I just want to wish everybody a happy Sport Purple for Platelets Day. Thanks for joining us.
Thank you, guys.